We've already started this presentation and it was about the course. So we're going to start on slide number 9, complex care. So when we talk about care that's complex, we talk about patients who are critically ill or who are extremely sick. And we also talk about patients who may not be as ill, but who have multiple chronic illnesses to manage, and that makes their care complex. So specialized treatment units began to pop up in the 1950s, and they recognized the necessity for specialty areas, especially for things like polio. And from those units, they saw that patients who were on those units did much better. They had much better outcomes. And so from that grew intensive care units. And these intensive care units continued to evolve through the 1960s. Implementation of CPR, improved management of hypovolemia and shock. Some of the medical advances that we saw as a result of the Vietnam War really propelled hospitals to develop intensive care units. We also saw better emergency medical services. So medical patients in the field were able to be saved. And then once they arrived at hospital, what were we going to do with them? Well, they had to have continued intensive care, and that care could not be met in the regular med-surg units. As technology advanced and procedures advanced, like renal transplant services, we saw the springing up of more and more hospitals having intensive care units and, in fact, having multiple intensive care units. These intensive care units, particularly in the early days, were very frightening places. They're still frightening now, but they were very unfriendly to family and visitors. The patients tended to be more easily managed if they were heavily sedated. And so patients, when they did have visitors, there was very little interaction between family and the person in the bed. Now, intermediate medical care units were intended for patients who need close observation but are not necessarily needing life-saving interventions. So, for example, people who are in intermediate care units might be patients who are on particular medication drips at low dosages. They're not really sick enough for the ICU, but the fact that they're on this particular, let's say, vasopressive medication like dopamine or IV nitroglycerin, that warrants their watching that patient very closely. They're too complex for traditional med-surg units, but they need more intervention. So when you think of these patients, you think of patients who are sort of in between critically ill and regular med-surg patients. So, for example, the newly diagnosed stable MI patient, where do you think they'd go? Or the patient on a ventilator, where would they go? Fresh post-op bowel obstruction patient, where do they go? Total hip replacement, where do they go? Maybe a newly burned patient, what kind of unit do you think that patient would be initially triaged to? So as you think of patients, you think normally uncomplicated patients will go to med-surg units. Patients who are critically ill and require intensive nursing and medical interventions continually will go to ICUs, and then people in between will usually go to intermediate care units, or oftentimes you hear them called step downs. So here you can see prioritization triage models for our critical care patients. People who are acutely ill requiring life-saving interventions, they're priority ones. Priority two, seriously ill patients who are in need of immediate medical interventions. Let's say maybe that's a patient who was your routine bowel obstruction but developed a sepsis. Priority three are critical ill patients who are not likely to recover from their disorders. So these are patients who it becomes very difficult to keep that patient alive, yet they require critical intervention. And priority four are patients who are likely to be terminally ill from whatever disorder they have. So one of the roles of the nurse in a high acuity setting is to continually assess and intervene on the patient's behalf. The plan of care is intensive. It requires a lot of nursing time. And what they have discovered is that the link between reduced mortality and complications occurs when patients who are critically ill are placed in units where they receive intensive nursing care. Now, it's not always nice to talk about, but patients are also part of a system that needs to be evaluated. So we have macro systems, which is like hospital systems as a whole, and we have micro systems, which would be maybe unit-based. And so the allocation of beds and resources depends on what's available. So what we're looking for is to deliver the most favorable outcomes to the most patients. There's ethical, economic, and legal concerns about how patients go in and out of intensive care units. Beds are limited. Sometimes beds are limited by the number of staff. So say, for example, we have a big snowstorm, a lot of people can't get into work, they're down several nurses in intensive care units. That might limit the amount of beds available in those units. When beds are tight, more patients move out of ICUs and into intermediate care units, okay? Also, we see patients moved around depending on their status or their code status. So a patient who is a full code and who it's been determined is unlikely to recover from their injuries may end up becoming a DNR patient, and then that patient moves out to the med-surg unit. So resources is something to consider with complex care or high acuity patients. Those of you who will be doing preceptorships in ICUs, you'll see all of this, but there's a lot of technology, a lot of bells, a lot of whistles, a lot of noises that go on, and the technology allows us to monitor the patient very closely, okay? These uses of technology give us a programmed outline of how to care for these patients and what is the best practice for them. The primary incentive for putting a patient in an intensive care unit is to access the technology, whether it be ventilators or, intra-aortic balloon pumps. We also see computers taking a big role in ICUs. We see a lot of decision-making trees that are used to manage patient care, and handheld devices are used at the bedside. However, technology tends to depersonalize some of the care, and there are disadvantages. So sometimes what happens is the patient no longer becomes the priority, but the nurse begins to treat the machines around the patient, so that's not very good. There seems to be a barrier between the technology sometimes and the ability of the nurse to actually touch the patient. A lot of times they're covered with these devices and there's little surface area for that touch. Patients feel depersonalized. Family members see this and watch the nurse and think that the care is depersonalized. This tends to evoke a lot of fear in the patients, can also contribute to the anxiety that they're feeling. Other things that happen is sometimes there's an over-reliance on the technology. We look at the technology and we forget we treat patients, not the technology. And that gets overlooked because there is so much technology. We also find that sometimes there's overload. So we see nurses sometimes become what they call alarm fatigued. There's so much noise and beeping going on that when an alarm goes off, people forget to go in and act upon that alarm. So the trick really is to find a balance between the technology and personalized nursing care. And the nurse in this setting has to bridge that gap. Joint Commission is an accrediting organization that accredits hospitals, which is directly linked to insurance reimbursement. They develop national patient safety goals, and part of the safety goals includes intensive care units. You've seen this already, computerized systems used to prevent errors. They prevent errors, but they don't stop errors, and the computerized system that's being used is no smarter than the nurse that's operating it. Things that promote safety in high acuity areas, strong educational foundation, so nurses who are highly trained and educated in their specialty area, Nurses who may be educated in that area but who are new to a particular unit need to have a solid orientation. There's also specialty certifications that ICU nurses can have, and a very strong physician-nurse relationship needs to occur where the nurse really becomes a partner with the physician in the decision-making process. So now we're going to talk about other concepts in complex care: cost, aging, populations, chronic diseases, and nursing workforce. When you look at this slide, you can see that hospital cost actually eats up the most healthcare dollars with 31%, followed by ambulatory care, which would be your things like clinics and physicians' offices. Government spends a fair amount, but government programs are less so. And what you notice on here is that drugs, only 10% of healthcare dollars in the United States is spent on pharmaceuticals. In reality, hospital care and physicians' offices and clinic services take up over half of the healthcare dollars in the United States. So one of the complexities of healthcare is patients who have multiple morbidities. So chronic illness is defined as the irreversible presence, accumulation, or latency of a disease state that impairs the patient's well-being and health. The goal of complex care in patients who have chronic illnesses is to maintain the function and prevention of further disability from this disease. So chronic disease exists in all age groups, but is the greatest in the geriatric population. 80% of the geriatric population has at least one chronic disease. It's very difficult to get to 65 without having at least one chronic illness. The number one chronic illness in the United States is hypertension. A second one is arthritis, followed by heart disease, and then cancer, diabetes, and then for some reason sinusitis, which seems odd, but that's just the facts. Now, one thing about complex care is we have patients oftentimes are stigmatized, and a stigma is a mark of shame or discredit. So many patients who are ill feel like they're being disvalued or discriminated against because they have an illness. This stigmatization affects the patient's ability to feel good about themselves, and their concept of self takes a hit. Patients who are ill oftentimes have decreased physical activity. They're not able to do things that they used to be able to do, so they're isolated. They're not able to continue with their professional role in the way that they used to be able to. And so that impacts the patient's self-concept and self-esteem. Okay. So you can think of a disease or a disability that can be associated with stigma. Self-efficacy is the ability to execute behavior that will get you to a desired outcome. So students who are sitting in a classroom and believe that they can actually master the material, they have positive self-efficacy. Self-efficacy is shaped by the patient's beliefs, how they feel, how they think, and what their motivation is. There's four major processes: cognitive, motivational, affective, and selection processes that patients need to have in order to develop self-efficacy. So one of the things that's associated with self-efficacy is this thing called locus of control. So how much can I control my own health behavior? And people who believe that they can control their own health behavior tend to have better outcomes than patients who think that they're just at the mercy of their health. Self-esteem is another one, okay, and that is the ability to like oneself and believe that you are worthy of good health. Coping is another one. It's strategies that people use in order to cope with or to deal with their health care issues. And then some things we see with patients is learned helplessness. And this would be a patient who has no locus of control, maybe poor self-esteem, and isn't able to cope well. They believe that no matter what they do in order to control their health, it's not going to be successful. So that's a learned helplessness, and that they're sort of at the mercy of everybody that they encounter in the healthcare system. So rehab nursing is a specialized area. There's actually quite a bit to it, where we take patients who have been ill, who have either actual or potential health problems and functional ability changes, and we get them to a point where they will be able to adapt